Now I would like to present Dr. Craig Smallwood and electrical impedance tomography.
Okay, thank you very much. Again, it's a pleasure to be here. This is the second part, and I hope that you can hear a little bit of the excitement in my voice, because this is the more important and more exciting piece of electrical impedance tomography. This morning we reviewed some of the methodology, but I just remind you of my conflicts of interest, received a little bit of support, not enough for me to scrape by and make a living, but enough to support some interesting research in our lab. So we're going to review the potential applications and also look at my personal laboratory and clinical experience in Boston and Harvard, and show you some really cool data that's starting to come out of our group, as well as some other collaborators throughout North America and Europe. So to remind you, this is the general setup. We have our patient. We purchased this box. Unfortunately, it wasn't free, but we've got it on loan or purchased it because we believe in the technology. We've placed the electrodes circumferentially around the chest. We have good contact with the machine. Each electrode is working correctly. During the workshop this afternoon, I'll teach you how to do that with one device we have here to demo. As a reminder, the principal physical principle, the electronic principle that we're utilizing to derive these images is impedance, and the Z is the letter that we denote voltage over amps. That's Ohm's law essentially, and very friendly. We love our lung changes in terms of the impedance in ohms. We go from 7 to 23, so there's a threefold increase in impedance when we take a breath in. And we looked at this. I'll just remind you that we're doing this many times a second, 20 times a second. We're rotating this around, taking measurements, and then reconstructing an image. We reviewed this, but just to reinforce, this is why it's of interest to me as a researcher and clinician. It's because we look at our chest films and also our CT images, and we see that there is a gross heterogeneity in terms of overdistension, normal ventilation, tidal recruitment, and alveolar collapse simultaneously in a single subject. And this is our normal image. But now let's start to look at some non-normal images. So this is a CT image. Obviously there's a ton of dorsal collapse down here. There's basically no ventilation here, and we would really want to have a lot of ventilation in a subject if we were taking care of this person in the ICU on the mechanical ventilator. So if a cartoon to kind of illustrate what the distribution of ventilation looks like across those three images of the lung. We're going to have up here probably a little bit of overdistension, which may reduce pulmonary blood flow. So ventilation without perfusion equals dead space. And then here we can have some areas where we might have reasonable gas exchange or a reasonable match between ventilation and perfusion. And down here we really have just a shunt, right? It's essentially we're only going to be having blood flow to that region, and there's no aeration, so no gas exchange. And the lung has a tremendous ability to compensate for areas where there is no ventilation. It just tries to constrict those vessels as much as possible to reduce blood flow and reduce the impact of a VQ mismatch. However, it can only do that to a certain degree. So it's never going to collapse those vessels completely, so you're always going to have some degree of shunting. And this is what that image looks like. So over here is obviously a pretty fancy CT image that we're very confident in and really high resolution, but we're going to have to expose our child to radiation in that case, and also send them off to the radiology department, and that's not always feasible with our critically ill children. But we could, however, apply these electrodes to the patient non-invasively. There's no harm to the baby outside of perhaps some skin irritation, but hopefully we can mitigate that with good care. But this is what the image looks like. So we have the control image over here, and we're going to be monitoring distribution of ventilation with the EIT. And so you can see in the ventral and mid-ventral regions, we just kind of arbitrarily drew these boxes around here. You can choose as a researcher or how to draw these boxes and where you place them in terms of what your clinical interest is. But here, along the ventral to dorsal axis, we have primarily ventilation in the upper regions of the lung, and obviously no ventilation in the dorsal regions, and so the percentages reflect that distribution. So let's talk about some actual applications. One of the first, and I think most obvious, is detection of a pneumothoraces. So this is from a review paper that my colleague and I wrote, and this is some real data. You'll see a lot of the earlier EIT publications tend to have two images, one CT or MRI right beside the EIT image, and that's really to convince us, because I think as clinicians and researchers it's prudent for us to be skeptical of any new technology until it's proven to us that it's worthwhile. But what you can see here is a radiographically identified pneumothoraces in this region of the lung, and you can consequently see the absence of ventilation in that area of the lung as well. However, and this is an important caveat, you can't just look at a region of ventilation that has previously had ventilation and then now has no ventilation, because the EIT isn't sensitive enough at this point to tell you whether or not that is specifically a pneumothorax. What it can tell you is there's no ventilation, but then it's up to you to go down your differential and decide what has caused that decrease in ventilation. So here you can see on the radiographic image, that is a pneumothorax, pretty obvious. No ventilation, and there's actually some literature to suggest that when you monitor continuously with EIT, or at least snapshots daily, you can detect pneumothoraces earlier than they would clinically manifest. I think that's one of the important keys. And what I love about this image too is simultaneously, no ventilation here, no ventilation here. Is this a pneumothorax? No, it's just alveolar collapse. But they're both black, and so those would both manifest on the EIT image similarly. So this is where the stuff starts to get a little bit exciting to me. I think a pneumothorax is a really pragmatic application. I think that that'll be a really good use. But where my heart and I think my mind is really parsing the optimization of mechanical ventilation. And really, it's a task that I think is more difficult in balancing alveolar overdistension and collapse, which happen simultaneously, as you saw in that image. So here's all the, I mean, this is actually not that complicated a math, but basically what people did was look at regional differences in distribution of ventilation and look at the periodicity of change to quantify whether or not that area was ventilated and now is not, and is at a certain part on the PV curve, if you recall what a PV curve looks like. And if it's on an upper portion, then we call that alveolar overdistension. If it's on a lower portion of that individual pixel PV curve, then we call it collapse. And so what we can do mathematically after taking the EIT images is quantify the areas of the lung where they're overdistended and collapsed. So you can see the orange here is Costa et al., their group published this several years ago. They looked at different levels of PEEP, and what they did was to demonstrate that as you escalate, so this is a baseline image, basically no differences, and we get two images. So we have a baseline with conventional ventilation settings with a discrete PEEP value, and then we'll look at areas where we're overdistending, and then this is going to be recruitment. So the orange is basically bad, and the bluer it gets as we step through this series of images, the better we're resolving atelectasis. So you can see here they're performing a recruitment maneuver in this subject, and what they're doing is they have to overdistend. So that's, I think, a consequence of a pulmonary recruitment is in order to recruit alveoli, you're going to have to sacrifice some of the healthy ones in the interim in order to open up those alveoli. So we see that we're causing a lot of overdistension, lots more overdistension, but we're starting to see resolution of the alveolar collapse in the dorsal region. And that is really a key region, I think, that's coming out in the literature, and I'll show you some of my experience in a few minutes. And then finally here, I mean, all orange, that seems really bad, and we wouldn't want to keep our patients there, because clearly if we overdistend them for long periods of time, we're going to be subjecting those areas of the lungs to volutrauma, barotrauma, ventilator-induced injury, potentially manifesting as a gross pneumothorax, which would be really bad, or a more subtle and long-term injury to the lung, which could prolong ventilation in our newborns who are especially susceptible. But the task would be to use this information to resolve atelectasis, and then if this case series continued on, you would see them then titrate the PEEP down, so reduce the settings to maintain recruitment in those dorsal regions, and then simultaneously decrease the proportion of overdistension. So that's the general theory behind using this principle. So here's a time base. So we looked at a few snapshots and looked at the actual image. You don't necessarily have to look at the image. You can look at the relative changes in global impedance as you increase PEEP or make recruitment maneuvers as a function of end expiratory lung volume. So end expiratory lung volume, we don't necessarily call FRC, but that's really a surrogate. That's what we use that nomenclature to denote. So you can see here we have baseline ventilation, and honestly this scale really isn't even that important. You could have arbitrary units, could be anything, doesn't exactly matter. But what's important is you have baseline ventilation here, so there's some value upon which after the patient exhales, there's going to be a global impedance value that's associated with that baseline. They breathe in, impedance increases, keep breathing, and that's basically baseline ventilation. What happens now, so at this time point, the clinician decides to increase the end expiratory pressure, basically a surrogate for a recruitment maneuver, and what we want to see is exactly what they're showing here. So we have a marked increase in the pressures, and we're going to see a marked increase in the impedance. So there's still during tidal recruitment, we're doing tidal recruitment here basically, and the end expiratory lung volume is going to be very high. We're probably going to have lots of overdistension during that period, lots of orange if we were to look at an image similar to that first. But then what we do is the titration phase. So we come down, we reduce the end expiratory pressure, but what we want to see is to make sure that when we reduce, so we're coming on the tail end of this, after we've performed the recruitment maneuver, we've hopefully resolved that atelectasis, that our baseline, our end expiratory lung volume by global impedance, isn't any worse. What we want to see is this. So it's greater than where we started. And so this would be the global improvement in end expiratory lung volume, which is a surrogate for FRC. Increased FRC means reduction of collapse, and hopefully VQ matching that will improve oxygenation, improve ventilation, and allow us to get by with lowering our tidal volume, these settings that are injurious to our subjects. So there are a few different ways you can do this. This is one that I think we have most experience with, and there are subsequent publications that I think validate our methodology. But identifying responders to recruitment maneuver. Recruitment maneuver is, I think, is something that you should approach with great trepidation. Although it's indicated, I think, in select subjects to improve mechanics for long-term benefits in terms of reducing ventilator lung injury and reducing length of ventilation. If you do it in patients who don't need it, you've just exposed them to a risk and increased pressure and volume that they are probably going to be potentially harmed from. So I think the thing that I'm most interested in, not just EIT, but EIT as a tool to do this, is finding those subjects who are going to respond, target them, apply the therapy that they need, and not give it to the patients who are not going to respond, thereby reducing the overall risk to the population and increasing the sensitivity of your intervention. So here's a recruitment maneuver. So we have, this is honestly a pretty typical type distribution. So there's pretty decent right-left distribution of ventilation among those regions that are ventilated, but again, not a whole lot in the lower dorsal regions of the lung. So we're going to set the regions of interest. You'll see that the convention is often along this ventral dorsal axis, 4 layers, just draw these big rectangles and call it a day. We're going to check if there's going to be an improvement in the homogeneity of ventilation, and in particular, we're going to pay attention to region of interest 4, the most dorsal region. You can call it whatever you want, it's just usually called 4. We perform the recruitment maneuver, and we compare the status before and after the recruitment maneuver. And what we would want to see on the image would be obviously ventilation in these lower regions, but you could also just look at the percentage distribution and look at from whatever you started. So if you started with near 0 or less than 5%, you want to see an increase in the ventilation in that region. And that region is most indicative of what's going to happen in the whole lung in terms of recruitment, because it's the hardest region to recruit. And this is just adding this is actually data from one of our subjects, and we performed a recruitment maneuver. This patient obviously responded because they've had a marked increase in overall ventilation, but in particular ventilation, or region of interest 4, we're getting some ventilation down there. So you can use trend information as well, and this is kind of along the same lines as that time plot that I showed you looking at the end expiratory lung pressure. This is one of the screens from our device that is from Draeger. This is kind of what the interface looks like. The thing that's nice about this methodology is it allows you to continuously record an image, but then you can go back and synchronize places in time that are of clinical interest. So you can see here we're obviously doing a recruitment maneuver and then titrating end expiratory pressure, and then doing another recruitment maneuver, titrating end expiratory pressure. And what we would want to do is use our little cursor here to look at time point 1, time point 2, and then we can apply that Costa et al. Research group methodology of expressing alveolar overdistension and resolution of atelectasis. So that you can basically use it's a touch screen, so you just point to whatever region of interest you're interested in, get the 2 time signals as well as those differences. So I have a few, I think, more diverse applications of EIT that I want to introduce to you guys. I think the most obvious is ventilation and distribution of ventilation. The most research has been done there. But I think researchers are keen to join the other component of ventilation, and that is perfusion. So if we can match ventilation to perfusion in all of our subjects, we will maximize the ventilation and thereby give us the best chance to reduce the ventilator lung injury. And so this is a couple of figures from Grant et al., who published this in Critical Care several years ago, but looking at pulsatile pulmonary perfusion distributed across the lung field. So one of the things with EIT is you'll notice if they put together their own methodology, well, people just choose their own colors. And so they're using yellow, this like heat map basically from blue to yellow. So you can see that there's different regions here. We can see the region of interest of the lung is in blue, and you can kind of just faintly see that. You kind of see almost that butterfly shape here. So differences in impedance when you're breathing. And then also the heart is right here. We kind of know that just anatomically. But then you can see the differences in pulsatile perfusion. And what they did was they plotted this over time. So you can see an ECG in black here. So P, QRS, complex, another one, and then look at the differences in impedance from the lung and from the heart. And it's honestly not as mature as the ventilation mapping, but the hope is that this type of methodology could be applied simultaneously, so that when we look at distribution fields of ventilation, we could also look at a map of perfusion and hopefully titrate our ventilation such that those 2 areas match, and that would be the best thing that we could target. So high-flow nasal cannula. I think high-flow nasal cannula is another really hot area of research, and I think it was a marriage of convenience more than anything else. But there's been a lot of researchers who are interested in trying to identify why high-flow nasal cannula works. There's lots of data in neonates and pediatrics and even adults that applying a high-flow nasal cannula can really reduce the need for a lot of other forms of non-invasive or even non-invasive ventilation. But it's still a little bit perplexing as to what actually is happening during high-flow nasal cannula that has led to the physiologic resolution of symptoms and subsequent avoidance of intubation. But you can see here, we're looking at the end expiratory lung volume, a surrogate, using the impedance. And you can see one of the theories of mechanisms of action is that high-flow nasal cannula actually does kind of apply an end expiratory pressure type therapy that previously people didn't suspect. They thought it was just washing out of dead space and just making your ventilation more efficient. Well, it also provides oxygenation support and can prevent some de-recruitment of alveoli, and this is basically demonstrating that that is the case with high-flow nasal cannula. So you can see here, no nasal cannula. They strap on the high-flow nasal cannula, crank up the flow, and you can see the end expiratory lung volume by global impedance increases, and then when you turn it off, it decreases. So it's not just washing out dead space. It has a more of a specific effect on functional residual capacity or end expiratory lung volume. And these are the statistical analyses just showing the differences in different areas of the lung. So they looked at anterior, posterior, and then the overall global differences in end expiratory lung volume by global impedance. And you can see off, lower, on, higher. So I think, oh no. Well, in the meantime, how many people use high-flow nasal cannula as a standard of care for neonates with respiratory failure? We got one. Couple hands going up. So you'll find that there's a lot of, I think, literature that's coming on as we speak to support high-flow nasal cannula. or even non-invasive positive pressure by a similar prong. We use these things called a RAM cannula, and it's really, I think, done wonders for neonates. All right, we're back in business. So the next portion of the lecture, before we have a few minutes for discussion or questions, hopefully, is my experience in the laboratory at Boston Children's and Harvard. And I'm going to show you probably mostly pediatric data. I think most of the experimentation, at least when it comes to ventilation in our hospital, tends to be in the bigger kids. It's mostly because we're a little bit anxious of experimenting these types of protocols on little babies. So the evolution of our care tends to be we experiment in the PICU a little bit more. Once we demonstrate that it's safe and efficacious, then we'll move it to the NICU and apply a similar methodology. But this is a study that was published just a few years ago. But we looked at reversal of dependent lung collapse as it's associated with lung recruitment in children with acute lung injury. And we had to be very brave. So we designed this protocol such that it was a very aggressive stepwise or staircase recruitment maneuver. And you guys know very well that there are basically two camps for lung recruitment. There's a sustained inflation, whereby you just increase the pressure to a specific amount for a specific amount of time. You've heard 30 for 30 or 40 for 40, so 40 centimeters of water for 40 seconds, or this staircase or stepwise recruitment maneuver that basically means you fix a delta pressure and then you step up the PEEP until you reach some maximum level or maximum level of recruitment. And in this case, we looked at both EIT as the endpoint as well as oxygenation. So I said brave because the numbers that we're about to apply to these patients is frightening. But this is the time sequence of the entire study. It took about 4 or 5 hours in total. This slide looks pretty busy, but basically we got a PV curve here. That's what that little increase and decrease in pressure is. We did volume control as baseline or whatever the baseline was. We did a sustained inflation, and then we took EIT images. We did lots of stuff here because with research, basically once you get a protocol approved, you want to answer as many questions as possible. So we were doing a lot of stuff before we got to the actual staircase. But we did a P-flex +2. If all that means is we look at the PV curve. So if the PV curve looks like this, we look at the lower inflection point and then set the PEEP 2 centimeters of water above that inflection point that was automatically determined on our ventilator. And then the phase C, or the maximal recruitment phase of the ventilator protocol, is this. And this is the brave part. So we fixed our delta pressure to 15 centimeters of water, and then we put them on a PEEP of 15, so 30 over 15. And you can see why we didn't want to start this in newborns. We didn't want to blow them up. So we started on a PEEP of 15 centimeters of water, and then every 5 minutes, we increased by 5 centimeters of water up to a maximum of a PEEP of 35, which meant 50 over 35. And the amount of time that was on each of these intervals is 5 total minutes. And after every 5 minutes, we collected an EIT image as well as a blood gas, and we looked for maximum lung opening by a combination of PaO2 plus PaCO2 of greater than 400. And these are some of the results. So you can see on the left-hand column, this was a successful lung recruitment patient. And so there were some patients who recruited and some who did not. And that was what we wanted to find in this study. So we wanted to have an equal distribution of patients who did respond, who didn't, and then we could look at the EIT images, design a protocol, design some processes by which we could predict who was going to respond and not respond, and then use that to infer clinical judgments going forward. But you can see here that primarily what we found was the collapse in region 4 was the most indicative of whether or not you were likely to recruit or not recruit. And that's why I mentioned that this morning, and I think I'm hoping to convince you of this afternoon. So you can see that the red here is our coloration of alveolar collapse. And you can see there's a lot of collapse here and not a whole lot of overdistension. In a patient who failed the lung recruitment at their Pmax, basically this would be like baseline ventilation, that's what this phase is. There's not a whole lot of collapse. A little bit of overdistension, but really just not a problem. And I think that's what we found, is they just didn't have a whole lot of recruitable alveoli. And then as we step up the pressure, you can see that we first have to overdistend a lot, and then once we overdistend enough and apply enough of a peak inspiratory and expiratory pressure, we see a resolution of that dorsal collapse, and then we can titrate the PEEP down and maintain alveolar recruitment. And over here, all we did was overdistend. We didn't reduce any atelectasis because they didn't have a lot. And this is a time series of one such subject who had a positive response to this lung recruitment methodology. So you can see collapse, overdistension, resolution of collapse, and then we stepped down to a reasonable level of pressure. So we started at, let's see here, we started at 19 over 12 centimeters of water, up to a maximum of 45 over 30. That was our maximum recruitment phase. And then we titrated down to 24 over 18, so obviously a little bit more pressure, but you can see we still have some overdistension, but less atelectasis. 18 over 14. Not too bad. All right, so now we're going to take a trip across the street. My office isn't in the same building that the animals are in, thankfully. But we go across the street into our Enders Research Complex, and this is our animal laboratory. So you can see we have a porcine model that I'll talk about in just a second. We have the EIT device over here. We also collected some other measurements which are not necessarily important, but we had the conventional ventilator here. We measured gas exchange. We talked about VO2 and VCO2 a little bit yesterday. We collected all that information as well, and then obviously monitored lung mechanics. And you can see here the band is wrapped around the thorax of the piglet. So this is, I think, a really cool study. So this was, I mentioned, at the early stages of my career in research, and what we did was we took that experience from our clinical patients, so lung recruitment, and we said, okay, we have enough information to design a methodology that we think is going to make a difference in terms of decision support for patients with lung injury. So we wanted to do this safely, and we didn't want to expose our patients to something that's just really, frankly, experimental. So we went to the animal lab and designed this study. So we wanted to guide mechanical ventilation with EIT images. So there's a little Yorkshire swine. What we did was we had to basically induce acute respiratory distress syndrome, and the way that we did that was saline lavage, which just washes out all the surfactant, which makes the lungs incredibly stiff. And then we augmented that injury with 20 mLs per kilo with a 0 of positive end expiratory pressure for a period of time. So we're just getting rid of all the surfactant. You just overdistend, tidal recruit, try to rip those alveoli apart as much as possible to induce injury. And so we had some animals that we used by ARDSNet, so small tidal volumes and a PEEP FiO2 grid. That was the standard protocol, and we just passively also monitored EIT. And then our EIT images, what we did was we took regional lung compliance every 30 minutes. So the whole protocol lasted 6 hours in total during ventilation. I mean, you're in the animal lab for the whole day, setting everything up and breaking it down, but 6 hours of actual protocolized ventilation. And we titrated positive end expiratory pressure between 0 and 25 based on the EIT images. And the PEEP was guided by the regional compliance, and we looked at overdistension and collapse. So here are probably two of the more important slides to take away from this publication. But we look at oxygenation by PF ratio, and we also look at time. So you can see the control is this dash line here, and the EIT guided group was the solid line. And what we found was a statistically significantly different difference in oxygenation. And you can see here that from baseline, there was like a real gigantic improvement in oxygenation in the AIT group that just wasn't really ever resolved with the ARDSNet protocolized controlled ventilation. And consequently, if we just look at oxygenation index, which I think is a more true representation of oxygenation in neonates and children, we see a similar finding. This is why it made a difference. Obviously, the PEEPs had to be different. That was the chief thing that we're changing during ventilation. And you can see right from hour 0, so we go to like the first 30-minute window, we're just on higher PEEP. And that's what we found the EIT device was telling us that ARDSNet wasn't telling us. ARDSNet was just totally satisfied to be on a relatively reasonable FiO2 and a lowish PEEP value. And you can see some other pulmonary mechanics as well. The dependent regional compliance, that would be the regions 3 and 4. You can see there was differences between the groups there, as well as the total respiratory system compliance, which we think this is more of an indicator of what is going to happen in the global respiratory system compliance. This would be from EIT, this would be from the mechanical ventilator. So we also, because I kind of told you the convention is with EIT that you have to go to the CT scanner and make sure that your images make sense, because that's just kind of what you do. And we took our piglet to the CT scanner, got some images, and here's what we have. So this is a representative image of one of the controlled subjects who just looks worse, right? I'm not a radiologist, but that looks worse than this. So this was our EIT guided group. So clearly there were important differences in the CT findings. And this is a comparison of the control and the EIT guided, but this time we're just comparing what the regional compliance looked like between those images, and clearly in the EIT guided group we have an increase in ventilation in the dorsal regions. We also performed some histopathology with our colleagues in the hospital, and on the left-hand column is the EIT guided group and the control is over here. And what you can see is in panel A, there's an absence of hyaline membranes following EIT guided, and there are hyaline membranes denoted in these regions, right there and right here in the control group. And then in panel C, you can see that there is an absence of airway fibrin. So this is like a nice clear airway here, and that is not the case in the control group. And those findings were statistically significant. We looked at the whole lung, and hyaline membranes and airway fibrin material, we found there were statistically significant differences. So last couple slides, I just wanted to make you aware that EIT is definitely an investigational technology in the United States right now. In places in Europe, especially Germany, people are using it clinically. But I will tell you that my personal bias or opinion about EIT is that right now, I think that we would have enough data to start using it in our ICU, albeit we can't do that without FDA's approval. But there is much work to be done for specific applications. And so we have a number of investigations to answer some open questions that we see in our ICU and in the literature in general. But we want to compare modes. So one thing that I think you see in the literature is that outside of some really gross metrics of mechanical ventilation, there's not a whole lot of good data to suggest that one mode is better than another. I know that there are probably skeptics in the room who would say volume guarantee or volume control is probably the beneficial mode, but I think you could argue with enough diligence that you could just control ventilation in pressure control. It just may mean it's less convenient because you have to be there to make sure that when the system compliance changes or the airway's resistance changes, you are there to change the pressure. But the question I think still remains, especially in the pediatric data, that what is the difference between pressure and volume control? Is there any difference in regional distribution? Because we can't just say that the volumes are the thing that are different or important. And also during spontaneous breathing too, there's a couple of new modes, and I'll show you one such finding. We're also doing a longitudinal study of regional ventilation. So this is just more observational. We don't want to look at the time series or the evolution or progression of disease and then subsequent resolution. And we're also looking at end expiratory lung volume with high flow nasal cannula ourselves. And in this case, we're trying to not just say that I think we believe that high flow nasal cannula works. I think clinically you can't really argue with that. There's lots of good data in pediatrics and neonates that to this point to support its utilization. However, what is not so clear is how to titrate the flow to maximize the benefit. So what we're doing is titrating different flows to look at different responses in terms of ventilation and oxygenation, as well as end expiratory lung volume by EIT. So this is from one investigation. This is a subject who is breathing spontaneously. We put him on pressure support ventilation here, and neurally adjusted ventilatory assist. If you've seen that, it's a mode that's available through McKay's Servo I or Servo U, and basically requires the insertion of a nasogastric tube that has an electrode array on it, and basically just says we're going to trigger the ventilator and titrate the pressure based on their electrical response in terms of the diaphragm. So the diaphragm contracts, we pick up that electric signal, and then it ramps up the ventilation with that signal. So it's a more complicated, perhaps more synchronous, maybe beneficial, maybe not. So what we wanted to do is before we start using NAVA, just look if there's any differences in regional distribution of ventilation. And you can see that for similar pressures, there are similar pressures here between NAVA and PSV, similar peak pressures. We're getting a lot more ventilation with NAVA by the EIT image. And this is basically a case series. These are 4 subjects. We're up to like 10 now, but we're going to write it up once we hit 12. So potential applications. I kind of gave you, I think, a survey of, probably a biased survey. I think I have my own interests, obviously, with the resolution of atelectasis. But pneumothorax, I think, is an interesting application, overdistension, balancing overdistension and collapse, end expiratory lung volume, ventilation perfusion matching. And I think this high flow nasal cannula, the last application is not necessarily that you'll always need EIT to apply high flow, but just the EIT can be a tremendous research tool as we learn how to optimize these therapies that are emerging in our NICU and PICUs. And that was my laboratory and clinical experience. And with that, thank you very much. I also put here, I don't think I've included this in other lectures, but I put this, this research gate. It's basically a social network, essentially, for researchers. But I do have my profile here. So a lot of the studies, if I was on the study, I try to upload it so it's available free of charge to anybody who goes there to my profile. So feel free to use that. You can also send me messages or keep up to date on the work that's coming out of my lab. Thank you.
Thank you very much, Craig Smallwood. Actually, you made us, all of us, eager to assist and to attend the workshop for electrical impedance. It's a brand new technology for us. Maybe it's a little bit complicated, but I'm sure you will make it very easy for us in the workshop. Inshallah. We will shift all the questions at the end of the session. And now,